as we're waiting outside the room, we just smell this awful like infection smell. And I'm thinking like, oh, the patient just passed by, somewhat septic. Well, no, it was apparently our patient, as soon as they tapped the chest, just had a gush of purulent drainage from the chest tube site. Is very, very pungent.
Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. Welcome back to the Rapid Response RN podcast. Today, I have a very special treat for you all. Joining me today are two critical care transport nurses. Welcome, Erik and Nykole.
Woo!
Hello.
So glad to have you guys. So, Erik and Nykole, we actually met through Rapid Response Academy. We all live in like different corners of the country, but we have come together from Rapid Response Academy. It has been so much fun getting to know them and hearing their stories. So Erik especially, he has this like super talent of being able to write out case studies. So in Rapid Response Academy, you can post questions or scenarios. How would you handle this? Have you guys ever seen this before? And Erik is the best writer, and he'll give you these cases of like patients that he cared for. And I am just so glued in, like, oh my gosh, what did he do next? No, he did it. He said that. The labs came back as that. Oh my gosh, that's so crazy. That's the EKG. Like I am all about it. He's such a good writer. So I love them. This particular case was especially interesting. It had so many good teaching points. So that is why I brought them on the podcast. So you get to hear from Erik about this patient he cared for, and also Nykole because of her expertise in pediatric critical care transport. Okay. So I said all that to say, you guys have awesome brains you're about to get to listen to. So before we dive into the case, I wanted just to take a minute to let my audience get to know you guys better. So Erik, I'll start with you. Can you just share like what brought you to nursing, what your journey has looked like so far? What are you currently doing in healthcare?
So yeah, my name's Erik. I started out my journey in healthcare as an EMT. I really enjoyed the pre-hospital environment, but I had wanted to go towards nursing. So I was working towards that. Became a nurse in 2021. And I started out ER nursing. Loved being bedside in the ER. That's kind of my go-to. But I also wanted to go into transport, critical care transport, because I worked in that field as an EMT. So I started doing that, really fell in love with that. So I'm currently working at Royal Ambulance in the Bay Area as a critical transport nurse. And I love that. It's such a unique niche, I'd say, where you have ER nursing, IC nursing kind of blended together into this nuanced field. And so that's what I'm currently doing right now.
Awesome. And then Nykole, how about you? How long have you been a nurse? What roles have you held in nursing? And like, what are you up to these days as a nurse?
Sure. So I've been a nurse for 17 years. I also started pre-hospital prior to that. It's about 20 years in healthcare total. I did some travel nursing and all of that, but currently I still work in the emergency department 1 day a week. And then I work on our pediatric critical care transport team 1 day a week as well. So working part-time now, but I've always worked EMS and ER. And really when that children's hospital locally opened a position for a ground transport team, I was like, this is perfect because I love the critical thinking of like the ER. I like the pediatric population. And I love like that transport role. Because like Erik said, it is kind of a niche group of nursing. Like you don't have a controlled environment. You're figuring things out. It's just very interesting, and you're using kind of a different part of your brain and different skill set. So that's where I'm at.
Awesome. So for people that don't really know what critical care transport nursing is, can either one of you just answer what is a critical care transport nurse? Like, what do you do all day? And then, like, what training or experience did you have to have before you could even apply for the position?
For my company, they look for a couple years at least of ER or ICU experience. Either or, both is definitely great if you have it. But a critical care transport, essentially, we are transporting the patient. If it's an emergent call or to a higher level of care, we're going from one center where they can't necessarily manage that patient's condition to a tertiary center. So usually those patients they've already been in the acute care setting at the sending hospital, and we have to continue that care to a higher level of care. That can really vary. For my company, we are not hospital affiliated, so that could be, it could be something very non-emergent, like transferring someone who needs to go to an appointment for whatever condition that they have, but they're on a ventilator, so they need critical care. Or it could be someone like the case we're talking about today, or, someone who maybe they had a STEMI, they went to a STEMI center, but they don't do open heart, and they need to go to a place that can do a CABG. So that's where we would come in. It really varies. All of our patients, there's an element of complexity and excitement there that I really like, because they're always going, if it's a higher level of care call, they're going somewhere because they can't be managed there. So there's some level of complexity to their case that makes it very interesting.
Gotcha. And Nykole, in your environment, you're going to hospitals that maybe their specialty is not pediatrics, and you show up as the pediatric specialist to kind of manage and stabilize this patient to get them to the places that are going to continue that critical care training. How about you, Nykole? What training or experience did you have to have for your particular position?
So I actually have my PHRN, and then through our facility, just a lot of training like PFCCS, which I recommend anyone who is taking care of critical care kids take this class. It's through the Society of Critical Care Medicine. And it's the fundamentals of critical care specifically for a pediatric patient. And our facility offers that to our outlying hospitals as well, so that when they get a PD patient that maybe they're not familiar with, they don't see a lot of them, it kind of helps them get the ball rolling. Ours is a little unique because at any point in that child's care, so say they roll into that ED right away, and this is a resuscitation or a bad breather, they can immediately call our intensivist and say, hey, we have this going on. Our intensivist will start then coordinating that care, and then either send us or flight, depending what's going on. So they'll give recommendations. And if those maybe recommendations aren't carried out by the time we get there, as the team, we're going to go ahead and stabilize that patient the rest of the way, make them safe for transport. And if I'm going, that patient's typically going to the ICU or the intermediate setting. And so typically I am dispatched to the ED. A few times I've gone to like the general peds floor for like an asthma or an RSV that's not turning around. And that care needs to be escalated and come to specifically a children's hospital. So I do have my PHRN, and then I do hold my birth.
For those that don't know, what does PHRN stand for?
Pre-hospital registered nurse. So the specific training for that is very similar to a paramedic internship, the class time, the ride time, and all of that. So some nurses who work pre-hospital will keep a paramedic license, and then they'll also hold an RN license. The PHRN is kind of like the marriage of the two. For me, that's just what I chose to pursue. It's not mandated by every transporting agents, but I know our system, like in our EMS system, that also allows me to work like a 911 truck if I wanted to do that as well. So just a little more broad spectrum for me.
Gotcha. And is that where you guys learn the additional skills that were outside of what you learned in nursing school, like intubation and decompression of attention pneumothorax and stuff like that? Okay. Gotcha. All right. Well, now that we know who you guys are and what you do all day, let's dive into this case. So Erik, can you just set the stage? What was the call you received from dispatch? What did you know going in? And then what did you discover upon your arrival to the hospital?
My crew and I, for my team, we transport with 2 EMTs and 1 CCTRN. So we were called to respond to a adult ER for a 11-year-old patient going to the local pediatric level 1 trauma, ER to ER. Initially, we were told it was a hemothorax. So that's all the information we're given, just demographics, where we're going, where to respond to, and the basic chief complaint. So we usually call to get a little bit of a story on what's going on. And I talked to the bedside nurse as we were responding. It sounded kind of a weird story. What I was told is that the patient had ran into a pole 5 weeks prior and was in some pain for a few days after that, and then was feeling better. And then after a couple of weeks, they noticed some shortness of breath. And that shortness of breath progressed to more of a marked shortness of breath with dizziness. The family had taken to like an urgent care clinic without much success. And then after another week of that, so a total of 5 weeks since this incident, patient was really like just breathing heavy, marked activity intolerance, and the patient was brought to the ED. And at the time I was talking to the nurse, they were preparing to insert a chest tube as the imaging had showed some fluid buildup. So that's all I was aware of at this point. So we were getting pretty close to the facility, just kind of getting prepped up for what we need to bring in. But yeah, that's what we were headed into.
Okay. So you're thinking, this is a 5-week-old trauma.
Yeah.
That they have to place a chest tube into 11-year-old. Okay, got it. All right. So as you arrive, what's going on at the hospital?
So they were still mobilizing their team for the procedure. I was a little surprised at that because, especially with how it sounded the patient was, how they were presenting, I was thinking that they would get that tube in right away. They were still waiting for the ketamine actually to arrive for conscious sedation. But when I saw the kiddo right off the bat, he was big sick.
Yeah. So when you say big sick, break that down to someone who has not seen big sick in a kid before. Like, what are you assessing from the doorway that you're like, this is no good?
So he is breathing extremely, extremely fast. He had a bit of a larger body habitus for an 11-year-old, so you can really see if there's like contractions as much or anything like that, but was definitely breathing very fast, very heavy. But on top of that, they looked just exhausted. They looked extremely tired. So they were warm, actually a little bit hot to the touch, and they were perfusing, but just a tired pediatric patient who's breathing heavy is never a good thing. And also was very alarming finding was no lung sounds on the left side.
Oh. So what they saw on the chest x-ray looked like fluid, but you're hearing no lung sounds on the left side at all.
Yeah, so I actually got to see the chest x-ray after the fact. It was I think I posted it on the rapid response.
Yeah, you did.
Yeah, it was very minimal at the top, but just kind of a solid mass of fluid there. But I was initially, when we came in, very concerned of, we got to get this tube in now. And something needs to happen, because it was very, just not a great thing to walk into.
And then, do you remember how his vital signs were doing? You said tachypnea, but was he tachycardic, or how was his blood pressure tolerating?
Blood pressure was actually 130/90. Heart rate about 150s. Their respiratory rate was in the 50s. O2 sat was actually 94, 95. They were on a cannula with end tidal. So they were at 4 liters, and they had an end tidal of 35.
Okay, got it. So just to like break it up, someone who hasn't seen a sick kid like this before, oftentimes you think, oh, the blood pressure is good, so the kid's stable. But we know that kids compensate for so long until they don't. And so the fact that you saw a kid who's supposed to be able to, have energy and like make eye contact and be talkative, if a kid looks like they're tiring out, all of us who've seen sick kids before know it's time to jump into action. We need to do something now. Like you said, I need to get the chest tube in now to expand this kid's lungs, to make some space for him to ventilate and oxygenate. Like we need to get going on this. Okay. So they finally got the ketamine. They get the tube in. How did that go?
So that went well. I was actually initially like, hey, I have ketamine. Let's do this right now. But the ketamine arrived pretty much right after I said that. So on our part, we just kind of stepped back a little bit. That's their procedure. And so they went in and started taking care of that. And with my crew, we were just prepping up to receive the patient. And that's when there was actually a pediatrician who came into the adult ER to help out with this patient. That's when they showed me the x-ray. We got a little bit more orders for the transport. But as we're waiting outside the room, we just smell this awful like infection smell. And I'm thinking like, oh, the patient just passed by somewhat septic. Well, no, it was apparently our patient, as soon as they tapped the chest, just had a gush of just purulent drainage from the chest tube site. Is very, very pungent to the point where it was, on like the sterile drapes that they were using and on the floor. Like it was pretty significant.
Oh my gosh. So you're in the hallway and you can smell the gush of purulent drainage coming out of this kid's chest.
Yes. Yeah. It was extremely like, it smelled like infection, just really, really just kind of like a putrid smell. And
Yes.
like I said, I thought it was, the 911 crew brought by this patient. I'm like, oh, something's going on. But no, it was our patient.
Oh, wow.
Yeah.
Okay. So initially the story is presenting like trauma. You're probably thinking like there's a hemothorax, right? Because you see fluid on the chest x-ray. Must be blood in there. But oh no, your nose said otherwise. Okay.
Yeah.
So this purulent drainage is coming out. Sorry to be nosy, but like what color was it?
It was brown. It looked like Jevity.
Oh gosh. Okay.
Your Jevity. Yeah. So my thought process here started to kind of shift a little bit because that was unexpected. And what I had noticed initially was the patient was a little bit warm to the touch. And then with this sign of infection, I started to go a little bit more down the sepsis pathway. The patient had not gotten any fluids. They had gotten a gram of Rocephin earlier in their stay. I'm not sure what prompted them to give that, but they were not, per the facility, the patient has an afebrile. I actually had a temp of, I think it was 1015 when I checked. So at that point, I had prepped up some fentanyl for post-procedure pain. The patient was very uncomfortable beforehand, so I was expecting that as well. But I also got fluid boluses ready to get that enacted through the transport. And what we were waiting on at that point was the patient to come out of the conscious sedation. The facility wanted to keep him there for that. And then we'll reevaluate and transport once the patient is out of sedation.
All right. So you're waiting for the kid to kind of wake up a little bit from his conscious sedation, and then you're going to load him on up and take him to your facility. I wanted to pause a little bit and talk with Nykole, because this is kind of a weird find, Nykole, to think, oh my gosh, empyema, pus in the chest. I thought this was a trauma. In your experience, what do you think was happening with this kid? How did he get pus in his chest from a trauma 5 weeks ago?
Well, as Erik was like sharing the case in our academy, like my first thought was when they were really like hemothorax, I think I would have like had a little bit, and I'm not trying to Monday morning quarterback because it's different when we're on the other side of it. But I think the acuteness of it doesn't really like speak to a hemothorax. Like we're 5 weeks out. So when he said like the fluid and an empyema, like my thought would be is maybe twofold. So like, did this kiddo have this trauma? We're splinting, right? Because we have maybe a rib fracture and now we're splinting. We got a little staph on our skin, a little strep, something going on. We get a little pneumonia. And an empyema, like that timeline can be like, I think the median timeline is what, like 15 to 18 days until like presentation. So did this kiddo have this trauma, splint, we have a little atelectasis, we get a little pneumonia in there, get a little staph, something. And then like now we have this pneumonia that now turned into an empyema. That would probably be like maybe what I would assume happened. And then I think, Erik, did you say he had elevated liver enzymes on his labs? I think we talked about that on our thread.
Yes, actually. Yeah. And that I did mention that too in my initial report of the case study. Because Sarah, you had just done your podcast on like a spontaneous peritonitis. Mm-hmm. And I was thinking something like after the fact, not during the fact. I was like, oh, I wonder if that was the case. Because he had no medical history. But on their labs, they did note some elevated liver enzymes.
Yeah. So like my thought was, did this kid have like maybe a little liver lack, a liver contusion that was, just missed? Or do we have a little elevated liver enzymes because we have sepsis? Like what, which came first?
Right.
Yeah.
Okay. So the kid has empyema. No wonder he's short of breath. No wonder he has exertional dyspnea because he's full of pus and it's taking up space inside his chest and his lungs are being squished. All right. So we have the chest tube in now. Yay. But what kinds of precautions did you take as far as the drainage and getting it out and monitoring the patient post-procedure?
Well, as we were waiting for the patient to come out of sedation, we were noticing a significant amount of output. And so every time we'd look at the chest tube setup, it would be more. And after a while, I think 20 minutes after the initial tap, the chest tube drainage system was at 700 of output. And so as the kid is coming out, he's feeling much better. He's reporting 0 out of 10 pain, which I was surprised because he was quite uncomfortable prior to the procedure. He's still very tachypnic, but there was some return of lung sounds on the left side, so they sounded very wet. Good. But with that amount of output, as we let the provider know, because we're getting ready to move over, he's coming out of sedation, let the provider know, and he's immediately alarmed, says, hey, clamp that tube, and we should go with lights and sirens.
Hey guys, I'll get back to the episode in just a second, but I wanted to pause to let you know that if you love my podcast but wish there were more of these awesome episodes, well, I have great news for you. There is more. My Rapid Response Academy is basically podcast 2.0, plus the huge added bonus of community. I love hosting this podcast, but it's just me, recording into a microphone often by myself. And this extroverted gal who loves to both teach and mentor nurses just wanted more. So in the community I created, I get to teach live every Friday and break down topics that I think every nurse needs to know. From deep dives into the pathophys of every emergency you can think of, to some of the heart of nursing topics as well, like how to advocate with confidence for your patient, how to de-escalate situations, how to deal with bullies on the unit, how to be an amazing preceptor and charge nurse, and some of the mindsets and boundaries that have helped me stay in nursing for the last 20 years, not burn out, and thrive at the bedside. I love the opportunity to answer your questions live, and it's such a joy to see nurses supporting each other in this community. So, if you're an acute care nurse that wants to expedite your growth as a nurse and invest in yourself so that you can provide the best care to your patients, you would love my Rapid Response Academy. So to learn more, I put a link in the show notes for you. Hope to see you there.
Wow. Okay. So I wanted to pause and just talk about the pathophys here. Isn't drainage a good thing? Like, aren't we trying to just dump all that stuff out of there? Like, get it out. Make some space inside that throat cavity. Get it all out. But the reason why he said clamp it is because when we pull off too much, too fast, we can actually cause a complication of large volume thoracentesis, which is re-expansion pulmonary edema. Super rare. It's like less than 1% of the time when you tap a chest that this happens, but I have seen it once. And so here's the pathophys here. If you have a pleural effusion, whether it's pus in there or just like serous fluid, for a long time, the lungs get a little bit squished. There's this whole like inflammatory cascade that goes on. All of the pulmonary capillaries are much more permeable, so fluid can shift in and outside of them more easily. And then whenever you tap the lung and there's a sudden re-expansion of it, there can actually be some damage if you do it too fast to like the endothelial cells of the lungs. And so we don't want to pull off too much too fast. We want to do it fairly slow, like initially get off a good amount, but then we would actually clamp it, because what can happen is you think, okay, the lungs just re-expand and fill with air, but with re-expansion pulmonary edema, they re-expand and fill with fluid because of that whole inflammatory cascade that's going on. So we want to do a slow re-expansion rather than a fast one, even though fast seems like a great idea. Do it, fix it. But we want to go real slow with it. So I know for adults, because adults is more my expertise, for adults, if you get to like 800 to a liter, clamp it. But for kids, is it weight-based? How much is too much when it comes to pulling off fluid from a kid's chest?
Oh, that's a great question. There is an element of it being weight-based, but we also have to remember our pediatric friends are really prone to fluid issues and then decompensating and going into an arrest. So like a kiddo will cardiac arrest, not because of a heart issue, but because of either a respiratory issue or like a volume, like sepsis issue. And so I think like just being mindful of what is this kid looking like after we get that. And that is a large amount coming out. But also, what are we doing to prepare to make sure our cardiac output is supported while we're draining this child? But we're not wanting to overload them either. If there's a pneumonia as well, we have a hepatomegaly, what else is going on with that kiddo? If they're febrile, they're already dry. So, I mean, if I was there seeing that, I would absolutely be wanting to make sure I had appropriate fluids. Obviously, they already gave antibiotics, probably a little tittle more of that. But what do I have respiratory wise? I would be very nervous about them tiring out, and needing would probably be where I would be at with that. And then I know the blood pressure was fine previously, but now we've given ketamine, fentanyl, and drained some fluids. What are we looking like pressure wise and like circulation wise?
I think if I was in Eric's shoes, I would just want to reach out to a specialist, which he did.
Your intensivist?
Yeah. And just ask, how much is too much? How much do you want me to be draining? When should I be concerned? What am I watching for? And not just be like willy-nilly, look at that, sure is draining great. And or like, you don't want to put the chest tube in and be like, sweet, look what we did, and then walk away and go to your lunch break. Like, we're actually watching the output for a good bit after we place a chest tube to make sure that we're not pulling too much, whether it's pediatric or adult. We don't want to pull too much off the patient. So what guidance did this pediatrician give to you as far as like for your transport?
In conjunction with the ER doc and the pediatrician that was there on scene, they said to clamp for 15 and unclamp after 15. And if you continue to have a significant amount of output after another 15, reclamp it again.
Okay.
We were looking at anywhere from a 30 to 40 minute transport. As far as the patient present, because they actually didn't get any fentanyl, I had prepped up fentanyl in anticipation, but the kiddo was denying pain for actually the entire transport. So only ketamine for the conscious sedation and then a local anesthetic for the chest tube placement.
Did he require any like nasal IV, heated high flow, like anything like that?
No, actually, we do have a high flow capability. We didn't have it on this unit. It's something that we have to bring from our station, but they were just on end tidal nasal cannula at 4 liters, and that's what we maintained them on. The big focus during the transport for me, as this kiddo was fitting the sepsis criteria and they were not following that pathway, was fluids. So the pediatrician had initially given me just some maintenance fluids to start with. That was before the pyemia was discovered. After that, I went into the sepsis, pediatric sepsis pathway. And so we did, he was 52 kilograms. So it was pretty much just, we're going to start with a liter. And I knew I probably wasn't going to get that in through the short transport, but at least play some catch up with the fluids there.
Gotcha. So I just looked it up. According to uptodate.com, for peds patients, the initial dump of 10 mLs per kilo would be allowed, and then clamp it, and then give it some time. They suggest an hour, and then unclamp again and drain a little bit more. But that way it's a slow re-expansion of that lung rather than a huge one. So if he's 52 kilos, that'd be about 500 mLs initially, 120, I guess, and then clamp and then kind of like slowly let that lung reinflate. So how did the kid's transport go? Have you heard back how he's doing at the other facility or what the outcome was?
We have not heard back yet. I've been trying to follow up on that, see if we can get that feedback on just their position, but no news just yet. The transport went well. My biggest concern was he had a lot of relief, but he was also breathing still quite fast in the 40 to 50 range. The end tidal level was maintaining like in the mid 30s range, and hemodynamics were okay. I did see a slight dip in blood pressure. We were in the 130 systolic and we went down to like low 100 systolic, but that rose up again. That was more of a transient change. Of note, through the transport, I did unclamp after 15 minutes. And again, it was just copious amounts. Like you turn your head and you look back like, oh gosh, where did this come from?
Wow.
So at the end of the transport, I rolled into the ER with it clamped. It was a total of 1.3 liters of output.
Wow.
So yeah, and that's including what was initially lost in the procedure as well as what they took for culturing and all that. But
wow. So that kid had been walking around with 1.3 or more liters of pus in his chest.
Well, yeah, incredible.
Dude, kids are so resilient.
Yeah.
crazy. Oh my goodness. Okay. So Erik, in hindsight, looking back on this case, if you were to share this case with, say, someone that you're orienting, what are like your takeaways, any pearls or potential pitfalls or wisdom advice that you'd want to give to someone from this particular case?
Well, I think for me, because I was not entirely familiar with the patho of re-expansion pulmonary edema, and I think for me, if I were to go back, I would want to get a little bit more clarification from the doctors. Like, hey, we're clamping for 15, unclamping for 15. What are we concerned about here? And also, I could tell that the doctor's like, oh, this is alarming. We need to go like sirens. But I didn't fully understand the patho at the time of what I should be looking for. So I think understanding that a little bit more would have been good on my part. But also just, not getting tunnel vision. So I think there's a little bit of tunnel vision with this kiddo. They had said he was afebrile, but he was febrile with me. And I think things could have gone maybe a little bit better if they had, caught that sepsis pathway sort of earlier on, gotten that going, and also jumping on that procedure a little bit quicker, because I called 20 minutes out and they hadn't done that yet, which when you have absent lung cells on one side for a kiddo, that's a pretty emergent one. But ultimately, I think I was happy with how his pain was managed. I didn't have to give any fentanyl, which I was ready to, but it's one of those things that you really, he was so uncomfortable, and I was so happy that, he's like feeling so much better after that intervention. And even though he's still a little tachypnic and, still, in the, not out of the woods yet by any means, he was able to, converse with my EMTs or talking about, favorite superheroes, things like that. He's just much more comfortable after the fact. But yeah, if I were to go back, definitely understanding a little bit more of like, okay, here's why we need to, slow down this output and what we're looking for.
Gotcha. That's good takeaways. The tunnel vision is real, man, especially when you're given information. We think this is a hemothorax because of trauma. You're like, okay, you just kind of naturally want to go down that pathway. But the fact that as you put the pieces together, you're like, oh, no, there's more to this story. This is a febrile kid. Woo, that smell. This is infection. Like, as you get more information, being open to other diagnoses, especially with trauma, it's so easy to find something like, oh, look at that. It's a femur fracture. And get so focused on the femur fracture that you don't maybe notice the more subtle signs of like a liver lack or like a splenic, like things that aren't quite as blaringly obvious in your face as a bone sticking out of the skin. So being open to multiple diagnoses for the same patient and continuing to always be assessing and looking for, potential complications.
Yeah. In reviewing the charting, that pediatrician and the doctor mentioned the ALT was 84 and the AST was 86. And this kid had no prior medical history recorded. That wasn't, as far as what I was going to do with that in the transport environment, well, not much, but that wasn't like really addressed, like the sepsis or, if there was a cause related to that. Everyone was so focused on this very old hemothorax until it wasn't.
Yeah. Nykole, how about you? When it comes to managing like critical care kiddos, any advice or recommendations for how to care for these patients, how to manage them in general? I mean, any takeaways that you have from this case?
My practice always is whenever I'm walking in the room, like, yeah, it's so nice to have a history on a patient, but like as that nurse, whether you're assuming care of a patient that's been there for a while or you're in the transport role and you're coming and picking up this patient, like we trust but verify. Like I'm still going to do my own assessment. That includes like that pediatric assessment triangle. What am I seeing as I walk in the room? And that's kind of is this kid sick or not sick? And just really then that's dictating kind of, okay, if this kid is sick, like in, work of breathing, I'm going to go ahead and intervene right there and like kind of fix those things before we move on to the others. And I think like with this kid, I think what we're like really hitting on is super important, that we can get tunnel vision. And I think like maybe pausing and putting the pieces together. But I do think it's reasonable, especially with a child, when people get a little more panicky. But if we can just take a deep breath and like realize, okay, he's been walking around with this for 5 weeks. What else could be going on? Because I think like maybe if had there been a little bit more of that process of like what Erik picked up on, like that sepsis protocol, then I think that could have maybe guided our care a little bit more preventatively before we put a chest tube in and had that large amount of output. Because I think when I hear kids, like I just get a little like, oh man, we just really dumped a bunch of fluid on this kid. We're super fortunate that he didn't have an issue with his cardiac output. And so like if we would have maybe been supporting prior, I think, it warded off any sort of bad juju, so to speak. But I do think your own assessment, even if you're getting a great story, because any patient can change, but in particular, I think kids like to change real quick on you. They're fine till they're not, like you said. And just being mindful that just that little bit can throw them over the edge, whether it's respiratory season or a fluid issue, can really cause them to have a pretty bad outcome. So I think with this kid too, with his liver enzymes being all elevated, I would have just been concerned about, like, does he have hepatomegaly? Can we assess for hepatomegaly? What's his fluid status? Are we going to overly resuscitate him with fluids and throw him into even more of a problem later on down the road, especially with a pneumonia already existing and then that fluid shift? So, yeah. I mean, I think Eric did a phenomenal job.
Absolutely. I agree. Nykole, one more question for you. When transporting a pediatric patient, say you have a long transport, how do you reassess, en route to make sure you're not fluid overloading the kid, because you don't have maybe some of the advanced hemodynamic monitoring that you might have in the pediatric ICU. Yep. As you're giving this fluid boluses, how would you make sure you're not giving too much?
Yeah, that's a super great question. So if I'm at all concerned about fluid overloading this patient, instead of doing the typical 20 per kilo, I start at 10. And after each aliquot that I'm giving, I'm auscultating, do we have crackles? And then I'm also checking that liver. Like, do we have a palpable, like, is there hepatomegaly that I am noticing? If that's the case, then I'm going to not do any more fluids. And then I'm going to look at either like a push dose or levo or something like that if we are worried about circulation. Also, cap refill is a great tool to assess how our kids are doing as well.
Yeah. Assessing cap refill peripherally and comparing it to the central, that tells us so much about kids. I've seen kids who actually were like awake and somewhat perky talking to me, and I pulled back the covers and was like, oh shoot, they have really bad cap refill. This kid is compensating amazingly well, but for how much longer, right? So cap refill is definitely a great indicator, and that respiratory rate too. Like you said, they compensate till they don't. So they'll just be like huffing and puffing along at 50 breaths a minute. And then when they start getting tired and their respiratory rate goes down, oh man, I am hustling at that point because I know that I'm running out of time.
And for every intervention, there should be a reassessment, right? Maybe we're not worried about hepatomegaly or crackles. Even if I'm giving a 20 per kilo and it's a normal, quote, normal kid, they don't have a cardiac history, like everything looks fine. After that first 20 per kilo, I'm still auscultating breath sounds because that kiddo can go into anything weird super quick, right?
Yeah. Okay, so then the final question is, let's say Eric showed up and they had already placed the chest tube, they'd already dumped 1,500 prior to his arrival, maybe not knowing the consequences of such a fast dump of fluid off the lungs. What would be the symptoms of re-expansion pulmonary edema? And then how would we treat someone who develops re-expansion pulmonary edema? So as far as what it looks like any other pulmonary edema, right? The patient might initially say, whew, I feel so much better. I'm breathing so much better. Until they're not. You notice, okay, wait, now they're tachypnic again? Like, what's going on? Their stats are dropping low again. We're having to go up on their oxygen again. Like, why are things shifting for the worse when they should have gotten better? The one case of re-expansion pulmonary edema that I was a part of, the patient had dumped, I want to say 1,200, and the nurse didn't realize that was a bad thing and called me after the fact. It was like, hey, my patient was doing better, but now I had them on a non-rebreather and they're requiring so much more oxygen than before. They're on 4 liters and now it's a non-rebreather. Can you come look at the patient? And that's when we figured out what was going on. She sounded super wet when I auscultated. She was super tachypnic, almost like her skin color was just not right, and I didn't know her baseline, but she just had that little hue of like grayish. We're like, this is not okay. So yeah, tachypnea is a symptom, increased work of breathing. So like not just the rate, but also like the work to get the air in, requiring more oxygen than they were before. And then upon auscultation, you would hear the crackles of their lungs. So if we find that, what do we do about it? Can't just like put a yank guard on and suction it all out.
With your patient, Sarah, did they do any sort of like albumin as well? Like for when they resuscitated her fluid wise, like a little positive pressure, some albumin, and then like pressure?
Did they do that prior? No. Did we do it afterwards? Yes. For this particular patient, we did not have to intubate her. I was thinking that we were gonna, but we ended up just putting her on like a good hefty amount of BiPAP with a lot of PEEP. I think, what else we did with her? She ended up doing okay. But I was really worried we'd have to intubate just because her work breathing was so intense. And she was satting like 90% on a non-rebreather, that's never a good sign. When we did her chest x-ray, there was so much fluid in there. You could see that the pleural effusion was better. We had drained that effectively, but now her lung tissue itself was full of fluid. So like the fluid was in the wrong spot. But yeah, sometimes we do have to intubate.
Yeah. Well, and I think that's like albumin can be such a great choice too for that fluid resuscitation. Like you have so much come off. Like obviously we need some fluid. We need to put in the right place. Yeah. So dry out those lungs with some PEEP. Mm-hmm. A little pressure if needed. Clamp some stuff down, move that fluid where it needs to go. But that's why I was asking about albumin, which, you don't really carry in the back of an ambulance. So
very true. Great. So to summarize, I think our big takeaways that everyone's echoing is don't have tunnel vision with patients. Always be open to new diagnoses that are surprising. Trust but verify, as you said, Nykole. And then if we're handling a patient that has some sort of fluid in their lungs, whether it's pus or blood or, serious fluid, whatever's coming out, we don't want up too much too fast. So as the test tube goes in, I think I asked the provider, how much is too much? When do you want me to clamp it? When do you want me to call you? Like just recommendations moving forward, and then follow those and document what you did just so that we are all on the same page and not overdoing it for the patient. And I think that about anything else you guys want to add?
I think one of the things that stood out to me from my crew, actually, which is really good with pediatric patients, especially those respiratory ones, you have to really present like a calm front and really connect with kiddos. Because, if they're already in respiratory distress and then they see all the adults around them running around, they're scared, they're going to get even more tachypnic. And that can push them over the edge right there. If they're already sitting on that edge of decompensation and then, their breathing becomes even more inefficient with, a little bit of panic, that could really be a poor outcome. And I have to shout out to my EMTs who really stepped up and were, talking with this kid, keeping him distracted, happy, smiling. Yeah, he was feeling a lot better, but they played a really great role in keeping him calm. And that's so important, especially with our pediatric patients.
Absolutely.
Adults are giants.
Yeah, it really is scary. Have you guys ever seen the videos, babies playing with snakes? And they have like zero fear at all because the adults that are handing them the snakes are also not fearful. But when the adult acts scared of the snake, then the baby also becomes scared of the snake. It's like little kiddos, they can just sense and almost mirror the reaction of the adults that they're with. And so what you said is so important, Eric. It seems minor, like taking time to explain to the kid what's happening, get their level and talk about superheroes. Like, is that a waste of time? Absolutely not, because they will mirror what you are putting on them. And if we are adding to their anxiety, we actually can worsen their vital signs. They become more tachypnic, more tachycardic. And so our therapeutic presence actually plays a role in treating the patient. Like it is part of our intervention. Like, yes, we're going to give a chest tube. Yes, we're going to give oxygen. Yes, we're going to give IV fluids. And we're also going to bring our therapeutic presence and help this patient recover. So thank you that's a great point to close. All right, guys. Well, thank you so much for sharing the story in Rapid Response Academy. Thank you for sharing your expertise and your heart and your brains with both Rapid Response Academy members and also now with my podcast community. This was such a good episode. I can't wait to share with everybody. You guys, thank you again. Have a great rest of your day.
Thank you.
Bye.
Bye. Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's,
That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.